Thank you. It's really good to be with you all, and I'm just sorry that we can't be physically in the same place and chat to each other. But it's great to see some familiar names, to hear your questions, and to be able to present to you. So thank you very much for this invitation. So over the next half an hour or so, I'm going to talk with you about looking into the future and some of the changing needs for community-based palliative care, particularly with a focus on what models of care might be appropriate. So I'm going to talk about what a model of care might be, and I'm going to talk a little bit about the state of the science internationally about models of community palliative care. And of course, because we've only got sort of half an hour or 40 minutes, I'm going to be a bit selective. This is not an exhaustive talk, but I've focused down on some interesting and thought-provoking bits of evidence, which I hope will help us think about the challenges for the future. So we've thought about this a little bit so far, but just to consider some of the questions. So it's a changing world, and the last year just tells us how rapidly changing it is. We have to think about the current and the future challenges for palliative care in the community. And really the models we need to think about whether it works, going back to Kathy's point about not efficacy, does it work in an ideal situation, but effectiveness, does it work in the real world, the world that you and I are trying to deliver care in? And also whether it's cost effective. So that isn't only about money, but it's about value for money, and what might work for the future. We need to think a little bit about the intervention as a whole, because if you or I think about the services that we work in, they're quite complicated. I know that when we were doing work on models of care in 2019, we decided to go and talk to services about what their model of care was. And we naively thought that an hour's interview might be enough. And of course, we spent a couple of hours, 3 hours, 4 hours, and we still hadn't got to the bottom of what the model of care actually was, because although we were talking with the leads of services, there is a lot of complexity about, yes, there are concrete things there, but there's also the nuance, which I think Charles raised in a question about how things are done, quality of how things are done. Are they done well? And how do we know they're being done well? We have to also think about the purpose of care, and I'm going to come back to that. I think Kathy touched on the purpose of care and the importance of keeping that at the forefront. We also need to say for whom, and we've talked about these issues of access, and I'll come back to that. Something about the timing of palliative care. So you've all heard of early palliative care, and I'd like to challenge us a little bit about that. And then we probably want to understand a little bit of how and why things work, because the more you understand that, the more you can keep the right components in there. And of course, we're trying to consider this within the nature of palliative care. So we know it's a holistic, personalised, human, empathetic care that we're talking about. We know it's complicated and complex. We also know that it's explicitly both for patients and families. And I'll come back to the family issue because I think that's a really important one. You can look and see at the way it's developed historically, and most models of care have developed historically. And I would refer you to two very good resources, both the WHO Global Atlas, which came out anew this year, but also the European Atlas from the Atlantis Palliative Care Research Group. So if you want to go and look and understand a bit about what is there, then those are good sources. So I'm going to talk a bit about the changing pattern of dying. I'm going to talk about some of the evidence, and I'm going to talk about ideas for the future. So first of all, the changing patterns of dying. So things are changing very rapidly, not even before the COVID pandemic, but the patterns of dying are changing fast. So we all are in countries with population growth, but also more importantly, changing age distribution. So there are more people at older ages. more long-term conditions, especially because of the changing age distributions, more cancer and more dementia. But more importantly, perhaps there are more multimorbidity, so people don't have one condition, and the siloed medical thinking of one disease doesn't fit, doesn't work, and we're being challenged about that on a daily basis. The trajectories of illness are also changing. If you look at the life extension literature, so the fact that as the years have gone by, we can all expect a longer life. The question has always been, do we expect more years at good health or added years with perhaps not very good health, poor health? And there's increasing evidence that some of the added years we're getting are in poor health. And what that means is that more people will have a dwindling trajectory where they progressively lose function over a matter of a year, 2 years, 3 years, 4 years. And so that changes the game really quite significantly. And alongside all those challenges, we really got a great deal more challenge about uncertainty in prognosis. An example would be some of the cardiac interventions that are now possible. I remember attending a grand round where the cardiologists were telling us about the more and more complex people that they could do sort of interventions which really gave them additional time. And that's actually part of the additional uncertainty about what interventions can be available and how do they change the trajectory of illness for people. So there's more uncertainty for some of these cardiac patients who have interventions. There's more uncertainty about some of the other conditions as the technical aspects of healthcare have changed and improved. So I like to just sort of have a few sort of headline thoughts in my mind, which help me put a bit of context around this. So this is kind of UK data, but it's not dissimilar. And it basically, for every 1,000 people who are living, about 9 will die. About 7 of those people will have a lot of palliative and end-of-life care needs prior to death, however you argue about measuring those. And those people who do have palliative and end-of-life care needs are disproportionately higher users of hospital services. And there's a very big difference. So if you don't have palliative needs, usually your use of hospital services is much less. Okay, and we know in the NHS that about a quarter of spend is on people in the last year of life. So this is a really important consideration if you want to take a systems-based approach. And then about 4 of those people will usually have a hospital bed as their last, and they will die in hospital. Here's data both from the UK and Ireland. So on the right is the Irish data from Peter May, Charles and others, just looking at the increase in the numbers of deaths. And this shows you really how rapidly it's changing, and it's changing even more rapidly in Ireland. So you can see there an increase of 84% up to 2046. So the numbers are changing really quite fast, and that's got to be a consideration for us. Also the changing patterns of multimorbidity is important. I've used this slide, even though it's a little bit old, because it's just got a great graphic. What it is showing you is a whole population with the age in years at the bottom, going from the younger to the older at the right-hand side. And that one chart on the left is 6 years earlier than the chart on the right. So you can see the absolute numbers of people with multimorbidity is changing quite fast. This is what people have called the tsunami of multimorbidity. So that whole idea about living extra years, we are not necessarily living the extra years with good health. We are increasingly living the extra years with multiple conditions. And this is now been widely replicated internationally across countries. And that's also changing very rapidly. So again, that changes who we see in palliative services. We've talked a little bit about socioeconomic status as well. And I wanted to present some data that I was part of a team that did a systematic review looking at the relationship between socioeconomic status and different measures of quality of care in the last year of life. It was a massive review, 209 studies, and this graph simply shows the relationship between level of deprivation and a log odds ratio for receipt of specialist palliative care. So because it's a log scale, it looks like the change is not very large, but in fact, this is quite a marked difference. And what you do see is a dose response. So the more deprived the area from which someone comes, or the more their socioeconomic status is poorer, the less likely they are to have access to any specialist palliative care services. And I think if you look at the wider literature on inequalities in healthcare, so we've had the revised Marmot report in the UK, but there's a number of other sources. You can see that the inequalities in health and social care are getting bigger, not smaller. And I would be extremely surprised if palliative care was not following that same trend. So I think we have to be really, really careful about how we reach out to those who might be in poorer socioeconomic quintiles or deciles or status, because if we don't do that, we are not overcoming these inequalities, but we're probably feeding them. So a really important wake-up call to all of us in services. This is an additional slide which looks at comorbidity by deprivation. And this is actually Scottish data, but again, it's very similar in other countries, that the different conditions are not only increasingly common, but they're increasingly more common in the deprived deciles. So the deep blue is showing the more deprived proportion or prevalence of these conditions: coronary heart disease, diabetes, COPD, and cancer. And so these are all feeding into those inequalities, and we just need to be aware of that and work out how to redress in relation to our geographical areas. We did have a bit of a discussion about family caregivers in the panel discussion. And here you can see that some of the OEC data on this, which shows very clearly how the changes in family caregivers are quite profound. So the frail older people are actually becoming more predominant. So yes, there are some adult children caring for their parents, but increasingly spousal care, partner care is becoming common in older people. And so that's why my comment in our discussion that not only is it the people living alone, but it's also the people living with only an older person to care for them. So those are some of the challenges, and those are some of the changing patterns of dying that we must think about. I'm just going to talk now about models of care and community models of care. We're thinking about what a model of care is, and it's been defined as the way in which health services are delivered. So a descriptive picture of practice which represents the real thing. A definition which I prefer is the one from Louise Brereton, which is about multiple components, including who delivers care, the interventions they deliver, where, to whom, when, how, and for what purpose. So that's my sort of working definition of a model. And it's important to think about it because those of you who are working in or with community services, think for a moment, who delivers the care? Has that been changed a bit in the pandemic? Is it possible to replace one kind of professional with another, or a professional with a volunteer, or a trained professional with a less trained professional? There's lots to think about there. The actual intervention, we talk about specialist palliative care, and we talk about generalist palliative care. I always think the specialist palliative care description is more about our insecurities. And I'd rather in some ways talk about the added support palliative care gives and the level of support that it might give, where we deliver it, to whom, when is a very important consideration. Given that those trajectories are changing, we've always traditionally been at the end of life until death, but there are other models of care in terms of the timing of care. And then we've had lots of challenges this year about face-to-face, you know, telephone, video, all sorts of other ways, how of delivering care. And again, bearing in mind the purpose and showing that we achieve the outcomes we intend. So if you look on the International Association for Hospice and Palliative Care website, they define 3 models of community palliative care. They talk about advisory, so maybe GPs, maybe palliative doctors, maybe community nurses, all going in to deliver care. Mainly palliative physicians and community palliative nurses going in at the request of GPs and community nurses. And they may have other disciplines on call for them, supporting them in the background or actively giving advisory care. But the kind of key feature of this model is that it's advisory. Now, it's a common model. Some people might find it a bit challenging. Why would it be that for the person in the middle of care, that they get one person to come and advise, they get another set of people to come and do the hands-on care, another person who's doing the prescribing, etc. So you can see why this might become quite fragmented. Another model would be a hands-on palliative nursing service, and it's usually nursing, where people are actually delivering hands-on care. And this is often a kind of hospice at home type model, but it may be other models which deliver care earlier in the trajectory. And the third model would be a comprehensive service. So everything is delivered from the palliative team. Now, this is less common for community palliative care in the UK and Ireland, but it may be common in some places where health resources are more limited and actually there isn't much additional extra care. So therefore the comprehensive service goes in. And of course, these 3 definitions are all a bit blurry. You know, you'll think about your own service and it may have elements of one or another, or it may have evolved over time from one to another. So I'm going to look at some evidence, and this is one piece of evidence. It's, as I've mentioned before, work by Louise Brereton and others. It was published 3 years ago, and it's a systematic review of reviews, okay? And one of the things they really highlight strongly is how poorly any of the evidence that we have actually describes the model of care. So they talk about heterogeneity, but also very poor reporting of models and a lack of consensus about, you know, what the model is and how it constitutes benefit to the patients. And I think this reflects the historical growth of palliative care over the years, that we mostly have just done things without thinking in great depth about what the models of care are. I'm also going to talk about another review by Daryl Bainbridge and work by Jan Gertner. So these are from different places, but they're all international reviews. The Bainbridge piece of work is very interesting because it's a systematic review of reviews. So not just are they bringing together the primary evidence, but they're bringing together the reviews of the primary evidence about in-home end-of-life care. And they include 17 systematic reviews and 2 narrative reviews. 40 individual studies with 30 different programs were identified. Now, the reason this systematic review is so interesting is that not only did they describe the components of the models of care and the benefits of the models of care, but they pushed hard to try and identify which components were most often associated with positive benefits. And that, for you and me, is really useful evidence because it tells us what elements of community-based care at the home, in the home, are actually the bits we've got to hang on to And so there we go. Most of the evidence was randomized controlled trials, but there was also a few other designs, quasi-experimental cohort post designs. And so they were looking for all of the components. So I've graphically represented that here with the pie chart, you know, the different bits, how they work together, were they structural or process elements, how they related to the outcomes. And they came up with a list. Now, the list is not necessarily in any order, except to say that they were the most frequent. So it starts with the most frequent. Interestingly, the most frequent was the linkage with hospital services. Second, multidisciplinary. Most of us might have put that right at the top. Expertise or training in palliative and end-of-life care, holistic approach to care, pain and symptom management, professional psychosocial support. So 18 of the services, the 30 services, were saying they provided professional psychosocial support. Linkage across community services, the team being on call around the clock, routine contact with the primary or secondary attending team, ongoing assessments, physician home visits, customized or individualized care, maybe case management, patient and family education, the doctor being available around the clock, team case rounds or case reviews, a specific focus on decision making, practical support, bereavement support, expert consultation with other providers, spiritual support, and volunteer services. So far, so good. I don't know that any of us would be hugely surprised. The only thing that surprises me is how many services didn't have these elements. And I guess looking at them, which ones would you pick out as being most strongly associated with benefit? And that's the really interesting one. So have a look and just think for yourself, which of these things would you think is the most linked to benefit? Okay, I hope you've all picked one or two. So the benefits that they looked at were about quality of life and well-being, satisfaction with care, improved functional status, improved pain and other symptoms, supporting home or preferred place of death, and overall reduction in health service utilisation. Clearly, the last one is a kind of commissioning perspective. So these are the ones that came out as most consistently associated with benefits. Linkage across community services. So we were talking earlier about integration. Clearly, there is something going on here about integration, which is more strongly associated with satisfaction, control of pain, and supporting home death. Routine contact with the primary or secondary attending team. So again, issue about integration here and communication, quality of life, well-being, non-pain symptoms, and supporting home death, and also physician home visits. And reading in more depth, I think this is about what happens in a crisis in the community. So can you parachute somebody who's perhaps a prescriber into the situation to kind of rescue the situation? And that was associated with better satisfaction, better control of symptoms, and reduced health care usage. So this is really interesting because it's not the obvious things that you would pick out as being most closely associated with benefit. They also looked at cost benefits, and the data on this is pretty patchy, but they did show significantly lower cost with palliative, with community palliative care in 9 studies, and then an additional 5 studies reported lower costs but without reaching significance or with no test of significance. And most often cost-effective care was associated with being on call around the clock home visits. So again, that crisis rescue kind of service, customized care driven by the individual needs, and the linkage with hospital and other services. It's giving a really strong message as what components are going to be particularly important for community models of care. The the review that Louise Brereton and others didn't look specifically at home-based palliative care, but most of the evidence they found was related to home-based palliative care. And they basically found increase in patient and family satisfaction wherever the setting was, but including the home-based care, highly valued by patients and families, which we already know. It's good to see it supported. And most of the evidence was about supporting and sustaining care at home. Now, they concluded that there was no specific model that they could say was more effective or cost effective. Now, it was really because the evidence was not clear enough. The models were not well described in the evidence. So therefore, they couldn't say one specific model was more useful than the other. And you can see how the Bainbridge review is actually much more useful because they pushed to see which elements were associated with benefit. They did in general, though, say there were positive benefits and increased likelihood of dying at home, and that's been borne out by the Cochrane review subsequently. And the cost data, they again concluded it was limited, but that in general the models were associated with cost savings due to reduction in healthcare, use of healthcare services. A note around this is that they largely didn't include informal care costs. And I know Peter May and Charles have been looking at informal care costs in more detail. The Gertner review, Dan Gertner did a systematic review and a meta-analysis about this, and I've included it because although this looks at cross settings, it has some really interesting lessons for us, and I wanted to draw our attention to those lessons. So these are the forest plots showing the results. So first of all, just for those of you who are less familiar with forest plots, if you look at the little graph in the middle, on the left, it favours standard care, and on the right, it favours specialist palliative care. And you can see that almost all of the blobs, which represent the individual studies, are showing up to the right, favouring specialist palliative care. There's one which actually disappears off the graph to the right. So good news, in general, specialist palliative care is associated with a better quality of life. What's more interesting, though, is to look at what's called early palliative care. So they picked out where people were being seen earlier in their illness trajectories. And you can see from this that there is much more benefit from palliative care intervention in those where they're getting early intervention as opposed to not early. Now, I would challenge the language here because to me, I think early palliative care is probably on-time palliative care, and not early palliative care is probably late palliative care. And I think this is a real challenge for us as we work more with different non-cancer conditions, multi-morbidity. We might need to think of models where we have short-term, on-time interventions which are much earlier in the trajectory, if we're actually going to get the maximum benefit and be as effective and cost-effective as we can in our models of care. And also, if you look at the difference between cancer and non-cancer, which was another presentation in this paper, you can see now non-cancer acute heart failure has disappeared to the right because actually they showed significant, a very big improvement. It wasn't so clear for this other study, but actually the evidence on non-cancer was so much more limited. So there's probably a lot to be gained in thinking about non-cancer patients and at what point in the trajectory do we intervene, perhaps short-term interventions much earlier, and really trying to think about how that might work out differently. But we also have to think about physician availability and home visits for crisis and complex situations. And we also need to think about the linkage and communication across services, not giving it a nominal position in our work, but giving it priority in our work, routine contacts with the primary and secondary care teams, and thinking hard about how we deliver out of hours accessibility and provision. I've talked a bit about the non-cancer models and the access of those with non-cancer into our services, which still there's a long way to go. And we might also want to think quite a bit about family caregivers, education and support programs, because it seems to me that as we have increasing pressure on our resources, supporting family caregivers has to be a really high priority. I've talked about the early access. I think Sofia Zambrano talked about concurrent access, so it's concurrent with active treatment. But I would say early is the wrong word. It has to be on time. And for us, it's about thinking how we can get into that space and actually work much earlier with other teams about identifying palliative needs, addressing them, maybe then stepping back and becoming involved again. So I would say we have to be very clear about the components of any clinical model of palliative care, and particularly if we're doing research, carefully think about what your model provides. Have a conversation in your team about what your model of care is. What are the most important components? What's core components? What sort of added extra when you've got the capacity? And I think having that conversation might actually start to open up quite a lot of thoughts about innovations, changes, be open to the possibility for doing things very differently. There is good evidence, both that palliative care in the community is highly valued and people are highly satisfied with care when they get it. There's also good evidence that it works in terms of quality of life, well-being and symptom improvement, with probably significant cost savings from acute care. But I would be very cautious about the evidence on informal care burden, because we don't know enough yet about the extent to which home care pushes both cost and burden onto informal caregivers. Most of the evidence is around cancer and with early palliative care, and we still need to accumulate more evidence on non-cancer and multimorbidity. But those elements to hang on to, integration, communication, out of hours, really important. So I'm going to end with a few ideas for the future. I think Kathy talked a bit about the things that matter to patients and families. And I would say we have to keep the purpose of our care right at the front, along with the things we know matter most for patients with advanced illness: good symptom pain control, family support, reducing burden on the family, having their priorities and preference listened to, getting a sense of resolution and peace and time for preparation. And having well-coordinated, well-integrated care with continuity. So those are obviously the right at the front of our vision and our minds as we think about how models of care change. The two things I would add into this, which are not there, is families and population access stroke inequalities. Now, I think we haven't focused enough on families. Somebody asked earlier about what happens when there's conflict between patient perspective and family perspective. And I would say often the reason those conflicts arrive is because we haven't had much opportunity to talk with families, give them the kind of support they're perhaps seeking, and help them to an understanding of what's happening. And so I think if we can focus on perhaps expanding some of the family support that we offer, that might be quite helpful. The other aspect, which I have emphasised in the panel discussion, and I have no qualms about emphasising again, is that we are serving, in most of our services, we're serving a population. We must understand the people who don't get into the service, who don't have access. So we need to go out and seek information about the population demographic, about population groups who we are and aren't reaching. So if you can keep those three things, the patients, the families, and population inequalities, addressing those inequalities, then I think keeping those three at the front of your mind will help as any models of care change. And beyond that, I think we can be quite innovative with our changes. And we do have to understand the evidence of what worked, which is why I've presented to you some kind of key papers which pull together a lot of evidence to give you some information about not just efficacy, but effectiveness in clinical practice. We need more evidence. We need more about non-cancer. We need more about multimorbidity, frailty, etc. But we have got some evidence and we don't use it. And I think I would also support Kathy's talk that we need point of care patient-centered outcome collection to know that we're delivering to those three focuses that I gave at the beginning: the patient, the family, and the access issues. So we still have to address some of the challenges of integration. Ask yourself how integrated your palliative service really is with the wider health services. You know, picking up the phone and talking to different people in other services takes time, and we often squeeze it into small moments in the day, but perhaps we should have dedicated time where we have those links. We have to think about the increasing demand on limited resources, so how we can be as efficient as possible. We have to think about the complexity that people have, and we also have to think about how we skill the wider health and social workforce in terms of their general skills. And we have to work on the non-cancer multimorbidity evidence. I still think, like Kathy, that we don't tend to see those with the most complex needs. We tend to see a cut across this triangle, some with the most complex needs, some with intermediate care needs, and some with less complex needs. We need to think quite radically about how we change that so that our focus is often on those with the more complex needs, and we are supporting other people to deliver to the intermediate needs. We still have thinking which is around the four main holistic domains of needs and how common those problems may be. But we've actually got to think about the interactions between people, families, and professionals. Somebody in the panel, we were talking about trying to shape care around individuals. We've got to be flexible. I think Brian was talking about that, being flexible and not expecting people to adapt to our care, but adapting our care to what they're looking for. We have to think how the system works to deliver. So this is where you would consider the access issues particularly. And we also have to think about societal understanding, so how our communities understand what we're trying to do. You know, it isn't, for them, we're not really a specialist palliative care service, we're really an added level of support. And we have to think about the time issue. So do we need to think about on-time palliative care earlier in the trajectory? And so this brings us all back to who delivers, and I think that's absolutely open for discussion. We have a model at the moment, but why should it be that way? But we do know from the evidence that having someone to visit in the complex crisis situation does make a difference. Components we deliver, we can rethink that completely, but we've got to hang on to linkage and communication between professionals as well as with patients and families, routine contact with the primary and secondary caring team, and we've got to hang on to the out of hours considerations. We've got to think about obviously the patients, but also family caregivers, and we have to work on demonstrating the outcomes. So I hope that has helped you with some of the thinking around community models of palliative care, and I also hope that the technology held up. Thank you.